So my name is Dr. Perry Maynard, and I am a board certified chiropractic neurologist. I have fellowships in traumatic brain injury rehabilitation, in vestibular rehabilitation, so rehab of the inner ear, and I am currently in a fellowship for dysautonomia, so things like POTS, vasovagal, syncope. So we are located in Denver, Colorado. So our clinic is Integrated Health Systems, and we have a few different practitioners. It's myself, Dr. Stedman, Dr. Hill, who is a nurse practitioner. We have therapists on board, physical therapists. We kind of have a whole gamut of individuals on our staff in hopes to work with a variety of different ailments. As I kind of mentioned before, one of my specialties is traumatic brain injuries and concussions. That's a good portion of the patients that I see. And that's why we have a wide variety of practitioners so that we can do things like vision therapy, vestibular therapy, cognitive rehab, hyperbaric, right? Try to kind of merge all these different therapies. And my hope is with today, you'll kind of have a little bit more of an understanding of why maybe certain therapies work, right? So as you're aware, there's not a very clear-cut standard of care for traumatic brain injuries or concussions. There are things that are kind of shown in the research, right? You have clinics that do hyperbaric oxygen therapy, or there are clinics that do vestibular rehab, or there are clinics that do, NAD, right? All these different things. And the question is, how do we figure out when each of those therapies would be beneficial, right? And the big key is understanding how do we really assess concussions, right? How do we understand what treatment makes the most sense? Because every concussion is very different, right? Now, concussion symptoms may be very similar across populations, as in headaches, dizziness, brain fog, fatigue, but those can be for many different reasons. And that's another hope of mine today, is that that becomes a little bit clearer, that just because two patients with dizziness both have concussions doesn't mean they should be getting the same treatment, okay? So to start, what I want to discuss is concussion subtypes. So we're starting to see it grow more and more in research and clinical practice, is this concept of subtyping concussions, right? And really there are 7 subtypes that we discuss, okay? And this is autonomic or migraine, affective, which is more anxiety, depression, more psychiatric issues that one develops post-head injury, cervical, cognitive, ocular motor or visual, vestibular, and sleep, right? What this looks like is you could have a concussion patient that comes in and their main chief complaint is sleep disturbances. Or you may have a concussion patient and their main chief complaint is depression, anxiety, or maybe it's dizziness. Or a lot of times it might be all of them, or it might be 3 of them. And so this is really important because this helps to better categorize what type of concussion this was and what therapy makes the most sense, right? If someone has vestibular complaints, vestibular rehab might make a ton of sense. If someone has affective disorders, this is where we might want to look at where sometimes medications, things like that can be helpful. We might want a therapist, we might want a counselor, we might want a psychologist, right? All these different things. So these are kind of the main subtypes. And what we're going to do is we're going to break out most of these subtypes. I'm not going to talk a ton on sleep just because of time, but I'm going to talk about the other ones, and I'm going to lump cognitive and affective together because I feel like they kind of can go hand in hand. We're going to discuss a little bit about them and how you test them, right? My other goal is I want you to leave today having an idea of what testing should be done if you or a loved one has suffered a head injury. So when you go to the doctor, I'm going to make the argument that someone's shining a light in your eyes, hitting a few reflexes and saying you look fine. That should be a warning for you that you need to look elsewhere, right? That there needs to be a lot more comprehensive work done when one has suffered concussion and they still have symptoms, right? So, when someone is still post-concussive symptoms for 6 months and someone hits a few reflexes and they say, nope, you're good, that wasn't an appropriate workup, okay? And that's my hope, that you can leave a little bit more well-armed to challenge whoever your healthcare provider is to say, hey, what about these tests? Who should I go to? Who do you know that might be able to help me out with these tests? So before we get started on those, let's talk a little bit about mechanism of action. What even happens in a concussion? If we don't really understand what happens with a concussion, how can we develop treatments to help a concussion heal? So really, I always explain to patients, one of two things happens with a concussion, right? We get what's called axonal shearing, and then we also get disruption in inflammation and energetics in the immune system in the brain, right? So if we think about the brain, right, the brain is mostly fat, right? And our big cortex sits on top of this thing called a brainstem, right? And it's kind of like this stalk. So it's like this, and then on top of it are these two big hemispheres that we think about. And the problem is in the brain, some of the different areas have different consistency. So think of it this way. Think of like a steak or a New York strip, where it's got that nice fat cap on the outside. And when you cook it, that fat becomes a very different consistency, and you can rub it like this, right? And you can kind of shear that fat off as it's rendered. This is kind of like the consistency in your brain, so that when I have an acceleration, deceleration force in my head, whether I hit my head, whether I have a whiplash injury, whatever it may be, where I slip and fall, that shear force creates this concept of axonal shearing, right? And that's what you see here, right? And so I always tell patients, it kind of takes your brain from being high-speed internet to AOL dial-up, right? For those who remember AOL dial-up, beep, boop, beep, boop, right? This long processing time. And so what happens is these hubs or these networks become disrupted, so they can no longer appropriately communicate with each other, right? And this is a lot of times where you see symptoms manifest, is that networks can no longer communicate efficiently. So that's one mechanism. The other large mechanism is this neurometabolic cascade of concussions, right? So other theories or mechanisms around the pathophysiology of concussions is alterations in the energetics, right? So what happens is that brain circuits become very unstable. Their ability to use glucose becomes very inefficient. The chemical gradients become altered, right? This is one big reason why things like seizures can sometimes occur after head injuries, is that the electrical activity in the brain can become very unstable. So when we're looking at a TBI or a concussion, we need to take this into consideration, because sometimes this can be a reason behind one's fatigue or brain fog, right? Is this neural inflammation? Is this disruption in energetics, and all those different things? So really, those are the two ways that I look at a head injury when I'm developing a treatment plan for an individual. We think, where do they lie on the spectrum? Is there still alterations in energetics or inflammation in the brain? Or is it just a connection issue, right? And we won't get heavily into how to differentiate that, and we won't get heavily into how to treat the neurometabolic cascade of a concussion. I think we have some other videos on that, or maybe we'll do a webinar just on that in the future, but it's something to consider, okay? So let's get into the first one. This is autonomic, okay? You may be asking, what is your autonomic nervous system? And some of you may be familiar, sympathetic, parasympathetic. I have a ton of lectures on autonomic nervous system, being that I see a lot of patients with dysautonomia and POTS. So we're not going to get super into it. We could spend a whole weekend on that topic. But ultimately, your autonomic nervous system is the part of your nervous system that regulates everything that is automatic. So you can see mucus production in your eyes, saliva production, heart rate, blood pressure, respiration, your gut moving, sweat, your ability to thermoregulate, your ability to empty your bladder, sexual function or sexual dysfunction. So you can kind of see this is a nice chart. You can see It does kind of all of these things, okay? And this is very commonly disrupted with concussions. And this is why it's not uncommon for individuals with concussions to develop things like POTS, which stands for postural orthostatic tachycardia syndrome, or individuals with concussions to faint or have blood pressure issues or issues in bowel and bladder function or sexual function or erectile dysfunction, things like that. That's where you start to see autonomic disruption. And so how do we test that? Well, one of the ways we can test that is with autonomic testing, okay? This traditionally is reserved for patients with dysautonomia or patients with POTS, which I use this testing on those individuals, but I also use it on individuals who have suffered concussions because it gives me a really good window into autonomic reflexes that regulate heart rate, blood pressure, all of those things. So here you can see, we won't spend too much time on this chart. The first section, the white section, is an individual at rest. The top line is continuous blood pressure. The bottom red is continuous heart rate. In the blue is what's called a deep breathing test. And this test is looking at what's called cardiovagal function. So how well can reflexes in your brain regulate heart rate and blood pressure with respiration? The next test in the light green is what's called a Valsalva. This test assesses what's called baroreceptor function, which is how well can my brain detect pressure changes in blood pressure. And then the light yellow test is what is called a tilt table test, which is traditionally used once again in individuals with syncope and fainting. This looks at, now when I stand, how well do I regulate heart rate and blood pressure? And then the last test is what's called a hand grip test, which looks at some other autonomic reflexes. Once again, I have other videos on these topics. If you want to learn more, just let us know, and we can always send you a link for some of the videos that dive a little bit deeper into autonomic nervous system testing. So you can see here, this first one is a somewhat normal test. As we get to the next one, you can see when you tilt the individual, that red goes really, really high. So you're seeing that their heart rate is rising and their blood pressure is tanking. So you can see in the blue, there's nice white gap or separation. You can see in the light yellow, all of a sudden heart rate drops and then, or heart rate raises and then blood pressure plummets below it, right? So this can give us a window into an individual where there might be an autonomic form of concussion. And you may be saying, why is this important? Well, these a lot of times are individuals who don't get better. So individuals who are like, I've done vision rehab, I've done vestibular rehab, I've done, you name it. I still have a lot of brain fog. I still have a lot of dizziness. My capacity is just not there. Like I just have no energy. A lot of times you find that there's autonomic issues. And actually, when you look at some research behind post-concussive headaches that just don't change, there is some growing research that it may be related to disrupted autonomics. Because at the end of the day, what this does is it affects blood flow to your brain, okay? If someone's autonomic nervous system is not working, it's going to be very hard to rehab and get better because your ANS simply helps you to partition fuel, right? It allows you only have so much blood, so that when I go to activate one area of my brain, I need to efficiently move blood there and take it away from other areas. Individuals with autonomic dysfunction, they don't do that well. So you could have the best rehab ever, but if you don't fix the ANS, then you're going to have a hard time getting that individual better. And this is why we want to screen for that. And we want to know, does an individual with a concussion have autonomic findings? If yes, that needs to be one of the first things that's addressed. And if not, then we know that they might do a little bit better. And the research is starting to support that individuals with tachycardia or fast heart rates have longer recovery times than individuals with concussions who don't have tachycardia. So we're now starting to see data support what we see clinically, in that if there is ANS dysfunction, individuals take a much longer time to get better. And the energy system is really why, okay? The next we're going to talk about is vestibular, right? This is a very, very common one. The vestibular system is very often affected in concussions. And here I've put together a little bit of a chart briefly, as you can see here on the left, in that there can be different issues affected in the vestibular system causing symptoms. So one can be the development of what's called BPPV. So sometimes with a traumatic hit to the head, you can dislodge crystals in your inner ear. And this is what could be manifesting in the dizziness or the vertigo. It's very easy to test and it's very easy to treat, as you can see here. And once again, you guys can get access to the slides as well. You can see here where I talk about cause and then rehabilitation. So exercise is used for that. The other is we can see VOR impairment. So this is impairment between the connection between the inner ear and the eyes. So this a lot of times will be individuals that get very dizzy with walking or quick head movements, or what's termed oscillopsia. So it's as if the world is bouncing on them. We can see visual motion sensitivity. That is very common post-head injury as individuals become very motion sensitive. Impaired postural control, so issues in balance. Cervicogenic dizziness, which we'll talk a little bit more when we get to the cervical region, and then exercise-induced dizziness. So these are very common things that individuals complain about post-head injury, and we need to figure out where that's coming from so we can figure out what therapy is going to most likely help that individual recover a little bit faster. So one of the things we do, and the other thing to remind you is that the tests I'm going to talk about are things that we do, but they're not all we do, right? If we went through everything, we'd be here for a while. So one of the best things post-head injury to look at is balance, but not just balance on the floor, eyes open, eyes closed, but balance where we manipulate vision, we manipulate surface, we manipulate sound. We start to manipulate all these different scenarios to look how well is the brain reweighting sensory information. So if we look back here, so eyes open, fixed surface, visual surroundings. How well can the brain use all its sensory systems to stay upright? And then when I close the eyes, how well can the brain say, okay, we no longer have vision. How can I get more input from my feet and my inner ear to stay balanced? And then what we might do is we might open one's eyes and then we may put them on a foam surface. So now we disrupt what their feet are saying. We say, how well can they ignore their feet and now rely on their vision, their inner ear? You can kind of see the pattern. We'll do things where we'll turn individuals' heads left, right, forward, backwards. And this really allows us to know how well the inner ear is contributing to balance, how well vision is contributing to balance, and how well what is called proprioception is contributing to balance, so that we can figure out why one is dizzy or why one is having balance issues post a concussion. So as you can see here, when we're looking at balance, we want to see somatosensory, which is proprioception, so muscles and joints in your feet, visual, vestibular, right, and which they're preferring. So this really lets us know, is one more visually dominant? Is one more relying on somatosensory information? And which one seems to be broken, right? So balance is really, really important, but we need to challenge it, right? Just doing it on a hard surface, eyes open and eyes closed, is not enough, okay? The next we're going to talk about is visual. So visual is very, very important. And when we look at visual, right, this could be people having issues with near targets, reading difficulties, eye strain, dizziness, double vision, motion sickness, right? So a lot of those same symptoms we talked about. So a lot of symptoms that one might attribute to being visual could be vestibular, but that's why we need to test eye movements, but we also need to compare that to how the inner ear looks as well. So when we look at what type of eye movements we really want to be testing, we want to be testing the VOR, which is what's called the vestibular ocular reflex. This is the reflex between my inner ear and my eyes. So when I quickly turn my head, how well can my eye stay focused on a target? Pursuits, this is my ability to track a target left and right smoothly. We know that gets disrupted in concussions. Saccades, my ability to quickly scan an environment. Fixation is just my ability to keep my eyes still on a target. And accommodation, this is an ability to move my eyes in and out. So these are really the 5 things that you really want to be looked at by your doctor, whether that is your primary care, whether that's your neurologist, whether that's your PT or your neurooptometrist, whoever it is. If you are seeing someone from a concussion and they are not assessing eye movements, I'm going to make the argument that they are missing a big piece, right? Because as you'll see here, and I apologize for this very wordy slide, but I'll give you the summary. This was a retrospective study. So they went back and looked in the past. And when they looked at 220 individuals, 160 who had a TBI, 60 who had suffered a stroke, 90% of the patients who suffered a TBI had some sort of deficit in ocular motor function. Now, you may be saying, sure, this is a small population size, but out of 200, out of 160 individuals, 90% of them had ocular motor deficits. So if you're not looking at eye movements or your practitioner is not looking at eye movements, you really need to find someone to make sure that they're not ocular motor deficits. And so one of the ways that we assess them is that we do what's called a VNG or a VOG. It stands for video nystagmography. This is a very common technology that is used in the ENT and otolaryngology realm, right? So this is testing to assess vestibular function and visual function. So it looks at inner ear reflexes, all of those visual reflexes I just looked at, and it looks at how well they're working together. So this is kind of like you get you kill two birds with one stone with VNG testing. You get an idea of how the inner ear works, you get an idea of how well the eyes work, and you get an idea of how well the brain is interpreting what both of those things are saying, right? So we run VOG or VNGs on most of our patients. I think some sort of ocular motor screen, you don't need this fancy technology. This all can be done bedside as well. The technology is just nice because it gives us graphs, it gives us data points so that we can compare and we can track outcomes. So that's the big reason I like it is it's really nice for education, but it's also really nice to treat or to track that treatment is actually changing what we want it to change, right? And we can have hard data points to show it. Okay, next is cognitive and affective. So we know with concussions, and data is starting to support it more and more, that more often than not, an area of our brain called our dorsolateral prefrontal cortex is affected. So our frontal lobe. So frontal lobe is more often than not affected when it comes to TBIs, okay, or concussions. And this is why we see a lot of cognitive and sometimes affective issues. So as you can see here, so this is a test we use that looks at cognitive function. Nothing special about this test. There's tons of cognitive tests out there. There is Cambridge Sciences. This is CNS Vitals. There's neuropsych testing. But what we want to look at, as you can see here, is verbal memory, visual memory, psychomotor speed, reaction time, complex attention, cognitive flexibility, right? And you can kind of see the list as we go down. And this is really nice because so often we have patients come in, they say, my brain is not working. Sometimes it's not totally clear what's wrong with executive function. So we really need to have a way to put a number to it and tease out what domain of cognition is affected. And this is really helpful because it allows us to have an idea of different networks, right? Example is, we know executive function is largely dorsolateral prefrontal cortex. We know that working memory is largely, prefrontal cortex. We know that there's specific circuits for verbal and visual memory. And so it can give us a window into different networks, but it also allows us to put a person in their age match percentile. So this will take your age range and it will compare it to a huge database of normative data to say, where are you on the continuum? Are you, as you can see here with this individual, their motor speed is in the top 75th percentile. Their reasoning is in the bottom 9th percentile, right? Which is not good. So this allows us to assess cognitive function. So if this is really good in an individual, we may be thinking, hey, executive and cognitive function looks really good. Maybe that's not the problem. When you look at affective disorders, that's where it becomes a little more difficult. This is where sometimes having a good neuropsychologist on board can be helpful, psychiatrists, counselors, other individuals to be able to screen for anxiety and depression, which is really important because unfortunately suicide rates do go up when we look at head injuries. And so it's really important that we take those very seriously and we get them treated and managed appropriately and get the right testing for them. So this is kind of an example of some testing that we do to assess cognitive function. Once again, to have an idea of, is this individual suffering a subclass of a cognitive type concussion? The last piece that we're going to talk about before we open it up for questions is cervical, right? And this is something very common we see as well. And why is this important? As you see in this diagram, my eyes, my inner ear, and my neck all are very integral in giving me spatial awareness. So it's very common for the neck to be disrupted in concussions, whether that's an individual who suffered a whiplash injury or just a head injury sometimes itself can then produce neck issues. A vestibular issue can cause neck issues. A visual issue can cause neck issue. A neck issue can cause visual issues like we'll talk about in a second. So as you can see here, what I'm always thinking about is this concept of reference frames, okay? My inner ear is what gives me a head reference frame. Where's my head in the world? Think about it like longitude, latitude. My inner ear tells me what longitude and latitude I am in the world and in gravity. And off of that, my vision can now understand where the world is relative to me. So the reason I know my water bottle is here to the right is I first know where I am. If I don't fully understand where I am, I may be lost visually. And this is where, honestly, I might, I probably differ opinion-wise from a lot of, let's say, optometrists, ophthalmologists, neuro-optometrists, in that I actually feel that your sense of gravity is paramount to everything else working. So a lot of times in the vision world, vision is the primary thing, right? You go to a vestibular therapist, it's the vestibular system. You go to a neuro-optometrist, it's vision. You go to a chiro or PT, it's all your neck. And really, you need to understand that they're all involved. I'm going to make the argument from my interpretation of the research and what I've seen clinically is that if your sense of gravity does not work, vision is going to be heavily disrupted. So what I'm saying is sometimes you do things and you fix the vestibular system and visual things like tracking, saccades, accommodation get better. And you may be saying, well, you didn't do any vision rehab. No, but we changed the context that the eyes were getting, right? Sometimes you have to do vision therapy, and sometimes neurooptometry is the best route for individuals with concussions. I love neurooptometry. I refer out to neurooptometrists all the time. They do great work. But I think it's important we know when it's appropriate and when an individual might benefit from maybe another therapy instead. And when we look at the neck, what the neck does really is it gives us an idea of where my head is relative to my body, right? So it's not uncommon to see whiplash or neck injuries create tremors in hands, coordination issues in hands, difficulty with balance, difficulty with tracking, because now you've spatially lost orientation between where your head is and your body is. Because if I reach out like this, that's one pattern, versus if I turn my trunk, but I keep looking here, that's another pattern. So I need to understand where my head is relative to my body so that I can take this bottle and I can take a sip of water and it's smooth, right? Versus you might have someone where they miss their face or they're shaking when they pick up the water bottle. I'm going to make the argument that disruption to the cervical spine can sometimes be the cause of that. It's not always the cause. There can be a variety of reasons for that, but it's important that we make sure that an individual who suffered a concussion, nothing is wrong with the cervical spine. And how we do that is a few different things. One is, of course, we want to make sure we do an appropriate orthopedic and neurological examination. So we want to make sure that there's not a fracture, damage to the ligaments, damage to the spinal cord, damage to nerve. So we want to look at kind of all these standard things that we are taught in school, but we want to look at more beyond that. And that's where we want to look at things like joint position error. This is looking at proprioception of the neck. So this is looking at how well does one understand where their head is in space. So we put a laser on the head, on the trunk, we move the head, we close the eyes, and we see how well can they get the laser back to center. This is what's called joint position error. We also want to look at what's called a smooth pursuit torsion test. This is where you have an individual track your thumb, and then you rotate the trunk and you redo it. So what you see a lot of times if the neck is causing issues is that one's tracking may be normal, and then you put torsion on the neck by turning the trunk, and all of a sudden their tracking becomes very uncoordinated. That's where you start to get concerned that a neck injury is now affecting visual processing. And so, yeah, maybe vision therapy could be helpful, but I'm going to make the argument in that case, appropriate management of the cervical spine might all of a sudden clear up visual disturbances. And I see this every day in clinic, but it's something that gets missed quite a bit. The other is balance testing, like we talked about. So what you're looking for here is that if an individual turns their head and then they become unstable, that could possibly be due to a neck injury. Balance really should be the same with your head left, right, forward, and backwards. It shouldn't change that much. If it does, then there could be a neck injury or an inner ear injury. And then the last one is looking at head-eye following. How well can I move my eyes and my head in unison together? So this is looking at coordination of my neck and my eyes working together. And what you see a lot of times in concussions is that this becomes very uncoordinated, or they're not able to sync their eyes with their neck very well. So these are the tests that are really helpful when an individual is suffering from a concussion and they're dizzy, they have headaches, they have brain fog, and we're asking, could their neck be involved? These are very common tests that let you know maybe they're involved, right? And this is where a lot of times you hear these miracle stories of chiropractors or massage therapists working on someone with a concussion, and that person's like, oh my gosh, I'm 100%. Unfortunately, more often than not, the provider's not totally sure. They're just providing their service and the patient gets better. That's where we know most likely there was a cervical component to this concussion. And my goal is that we can screen for these things early so we can figure out and have a patient say, hey, you know what? You might do really well with PT. You might do really well with chiropractic or massage or someone working on your neck. That makes sense. And we know that makes sense because this testing is abnormal. Versus if I have an individual with a cognitive affective concussion and they go to the chiro or massage therapist and they're like, I don't know why this isn't working. This works for my friend down the street. Well, it could be a totally different mechanism, right? And so you're starting to see that there's no one treatment for a concussion. There is a multitude of treatments that have shown efficacy clinically and in the research, but that's a big reason why there's not a good standard of care, is that I don't think we're doing a good job classifying concussions. And my hope is now that we're doing a better job classifying, we can start to drive research to say what kind of therapy is good for a cognitive concussion or affective concussion or vestibular, things like that. So that's my hope with this, and that's what we try to do clinically. And from my experience, that helps to expedite the process and to limit time and money that patients spend, right? So many patients with concussions, they go from doctor to doctor, they go to acupuncture, they go to their chiro, they go to their PT, they go to vision therapy, all just guessing, hoping that something will stick. And the problem is a lot of practitioners are saying, hey, I've treated this before and I've seen it get better, so let's try it. And that's not always the best way to go about it. My hope is for more and more clinicians to be able to kind of go through this thought process so that they can either have the tools or know when to refer to a neurooptometrist, know when to refer to a psychologist, know when to refer for hyperbaric and things like that. So really, that is what we try to do clinically. And that's why we've tried to create a great network of individuals around Colorado, but also around the country, so that we can kind of get people to the right place at the right time. And this saves time, money, and just keeping from doctor fatigue. Here are just a few studies. This is a randomized controlled trial in the British Journal of Medicine, just discussing and showing that outcomes after 8 weeks of adding in cervical spine work had better outcomes than just single kind of modalities. Same thing here, just another research paper looking at the benefit of adding in improvement of range of motion, improvement of deep neck flexor strength, proprioception, all of those having a benefit on accelerating one's recovery from a head injury. This whole narrative of we need to sit and rest, I'm hoping we'll stop saying that soon, because even if you look at the concussion consensus statement, so this is a consensus statement that once every, I think, 4 years, experts on concussions get together from around the world. They review research, they review data. The last one was, I'm pretty sure, in Berlin, if I'm correct. And they review all the most up-to-date data, and they decide what should the new standard of care be for concussions. And even the consensus statement does not support rest past 2 to 4 weeks. They state that if an individual is still having symptoms post 2 to 4 weeks, they need to seek some sort of intervention, whether that is vision therapy, vestibular rehab, whatever it may be, because what they're starting to notice is that if an individual has not gotten better on their own in that timeline, then something needs to be done, because the brain does not fix itself, right? The course of a concussion is about a month between the alterations and inflammation and things like that. There's some data showing that it can take upwards of a month to re-normalize mitochondria function within the brain. So if one is not symptom-free at that point, something needs to be done. If you are 6 months and your doctor continues to tell you more rest, sit in a dark room, I would make the argument you need to speak to other people and get other opinions, because that opinion is not supported by the most up-to-date science that you see in the Berlin concussion consensus statement, which is the best we have as of right now. So to kind of review, when we're looking at an examination, we want someone who's taking a detailed history, looking at mental health, looking at incident history. All of these give us a really good idea of what happened with the injury. Sometimes we'll run blood work because we want to see if there's other metabolic issues affecting the recovery. And then we want a full neurological examination, orthopedic, and autonomic nervous system examination, along with all those things that we discussed. Like I said, this list is not everything. There are other good things, but if these things are getting looked at, that is a great start. And you are going to catch a lot of kind of symptoms. And if you get a lot of that testing done, that will really help to dial in why you might still be having concussion symptoms, and then figure out who is the best provider to give you the best care from that. So kind of to wrap it up, my big things are act sooner rather than later. Like I said, don't wait. If you're 6 months post concussion and you're still sitting in a dark room and you're being told to stay in a dark room, take action. Find a provider who's going to do these types of assessment and be able to get to the root of why the symptoms are occurring and get you to the right provider so that you can get, hopefully start getting symptom relief. And the other big piece is it's never too late. I've seen patients post 6 months head injury. I've seen patients post a decade. And now, of course, the longer, the more difficult it definitely is. The sooner you can get on top of these things, the better. But we know with neuroplasticity that things can still change, right? You can still see improvements in balance, cognition, reaction time, even years after a head injury, right? So this idea also that still goes around that the brain can't change, that couldn't be farther from the truth, right? The brain is a very plastic thing. that changes. And the last thing is that I want to kind of leave you with is we do offer free 30-minute consults. This allows me a few different things. If an individual is in another state, it allows me to review their case and find them a provider in an area close to them. So maybe someone's in Boston, or maybe someone's in Chicago or Florida. It can help me to say, hey, here's a really good person for you to find. Or it allows me to chat with patients and see if there might be something we might be able to help with the case. So it's something that, I like to do so that I can help get people to the right place at the right time, so that they're not going through this kind of nightmare that is healthcare of seeing, over a dozen doctors. So I hope that was helpful. I am now going to open it up to questions. If anyone has any questions, you can either write them into the chat, or honestly, just you can should be able to unmute yourself, and I'm happy to answer any questions.
Hi, can you hear me?
I can hear you.
Hi, I would be coming in from out of town, and I've already had a consult with you. And I was wondering, I feel like I'm a lot of those things. Would you do all of that testing?
You cut out for a second. Could you finish that last part of your question?
So would you do all of those tests because I feel like I'm a lot of those things.
That's a great question. Most of the time, I usually do most of the testing anyways. I mean, occasionally when it seems so clear cut that it's one thing, sometimes I won't burden someone with excessive amount of testing, but more often than not, I'd rather be thorough and make sure we just don't assume. So I'd say 80% of the time, I'm running comprehensive testing on everyone just to make sure there's nothing that's being missed. Like I said, if it seems very clear cut, sometimes we won't run those things. But most likely, answer your question is yes.
Okay. And so like if I still have headaches over a year and a half later, and it seems to happen with weather, that's the autonomic nervous system, right?
It can be, when you're looking at barometric pressure changes, it can be a few things. It can be vestibular, it can be autonomic. The other thing is that the tympanic membrane in the inner ear, which is the membrane between your external and your middle ear, is very innervated to what's called your trigeminal system. And your trigeminal system is a pain network in your brain. It's what interprets pain in your face and in your neck. And so sometimes fluctuations in that can affect those pain circuits. There's actually a migraine device right now being developed that harnesses that mechanism, where it's earplugs that fluctuates that tympanic membrane to abort migraine. So it can be autonomic, but it also very much can be vestibular as well as just how your brain is interpreting pain. So sometimes it can be a sign that pain networks are hyperactive. So you're not wrong, but it can be a few other things as well.
Yeah. I've also heard that your blood-brain barrier can have micro tears in them. I don't know.
Yeah, so we do know that with concussions, there is disruption in the blood-brain barrier. Unfortunately, we don't really have a good test for that. The only testing that can be done is looking at, is your immune system attacking your blood-brain barrier? So what can be done to see if there's blood-brain disruption is looking to see, are there antibodies against it? And if so, that's a pretty good sign that there's breakdown in that junction. But that's really the best we have. Imaging won't really tell you, blood work won't really tell you. So you can look kind of non-specific at immune markers, and that can give you kind of an idea.
Thank you.
You're welcome. All right. All right, open it up. Anyone for any more questions? Like I said, feel free to type into the chat or unmute yourself, and I will be happy to answer. So we'll give people a little bit longer. Let's see, I got something in the chat. So great question. So this was a question. Can you tell from a phone consult if someone is a good fit for your therapies? You do. And could you likely help them for those out of state? That's a great question. Honestly, that's a big reason why we do these consults, is to figure out if that's the case. So to answer your question, yes. I can have a pretty good idea if it makes sense for you to come to our clinic or go to a clinic similar to ours somewhere in the country. This is why, usually during the consults, I review the history, I review the case, everything you've done, who you've seen, the testing, and I say, here are things that still should be looked at, here are things that we can do, or here's an individual a little bit closer that can help you with those things. So that is a big reason for the consult, is to figure out if we think we can be of help, or if we think someone else might be of better use. So yes, that is largely what we try to do with the consults, if that helps to answer your question. Okay. Any other questions? I'll give a minute or two for anyone to ask any more questions. And if not, then we can wrap it up for the night, and individuals can get to dinner or whatever they need to do. I don't want to keep everyone all night.
Yeah. I have one more question.
Yeah, shoot.
When you find these problems, are there things you can, like, is it all physical therapy that helps you improve, or drugs, or?
Yeah, great question. So yeah, it can be a combination of physical therapy, right? So like we talked about things like vision therapy, balance rehab, cognitive rehab, harnessing the concept of neuroplasticity. But that's where also we use things like hyperbaric oxygen therapy. We use things like peptide therapies, or so what actually our nurse practitioner does, or what I'll sometimes do with other providers, is using concepts from like regenerative medicine or anti-aging. So things that we look at to try to keep us young or try to reverse the clock, but use those towards head injuries. So that might be things like peptides, that might be things like NAD, glutathione. I'd say rarely do we intervene with medication, right? And that would be the role of our nurse practitioner if we did, but rarely do I find medications to be very helpful for TBIs. Really, most of the time, medications are going to be symptom management. I don't find that they really fix the problem. So that's why we don't tend to go to medications. Once again, in affective disorders, sometimes medications can be helpful for depression, anxiety, or psychiatric issues. Sometimes medications can be helpful for post-concussive headaches, but I usually don't go that route until we've exhausted all other options. So there is more than just the physical therapy. Like I said, that's where nutrition, supplements, regenerative medicine techniques, hyperbaric, things like that will also add in, because those help to work on the metabolic function of the brain, or that neurometabolic cascade that we discussed earlier. Where the physical therapy comes into play is the axonal shearing, right? It helps to create new connections. So you can think of the different therapies kind of in that way. So hopefully that was helpful. Looks like we have another question. For us out of state, could we do a short-term intensive therapy program, or is it better if the therapy is over the course of a month? That's a great question. So we do see a lot of individuals from out of state. And a lot of times we will do anywhere from 1 to 2 to, I've even done month-long intensives where individuals fly out and we work with them for an extended period of time. And usually what the goal is with those is to kind of get the needle moving. It's 1, to figure out what's causing their symptoms. 2, figure out what therapies are going to make the most sense to get better. 3, start those therapies to start moving the needle, and then create an at-home therapy program that they can continue at home to continue to get better. Or sometimes then when they go back to their home, we talk to their provider back home, or we find a provider back home that can continue the therapies that we did in office. So intensives are great. We do them a lot. But a lot of times you hear these miracle stories of, I did a week intensive and all my problems went away. And that happens, but that's the exception, not the rule. A lot of times you can get the needle moving and people start feeling better, but there needs to be consistent care afterwards, right? They need to be doing therapies for sometimes, months afterwards to really make sure that those changes stick. So that is an option. And we see individuals out of state all the time. And it can work really, really well. And then we do a lot to follow up afterwards, giving them at-home programs, really trying to set them up to succeed. So that's a great question. Any other questions? And if not, then, like I said, I would like to thank everyone for coming out tonight. Thank you for spending your Tuesday evening with me. I know there's a lot of other things you can be doing. It's a beautiful day here in Denver, but I hope everyone has a great evening. Like I said, this will be recorded so that if you want access and you want to watch it again, just let us know. If you would love to chat with us about either finding a provider near you or you're interested in working with us, then we'd be happy to set up a consult. We'd love to work with you. Let's see, we have one more question. Do intensives tend to really flare symptoms in the process? Great question. When you look at brain injury rehab, traditionally, a lot of people go to vestibular rehab or vision rehab, and you'll hear this quite often. I felt really bad for 6 months, and then all of a sudden I felt better, right? They go to therapy, they feel very dizzy and nauseous. My opinion is, if you're working at someone's appropriate metabolic rate or you're doing appropriate therapies, that shouldn't really happen a ton. Early on, it can sometimes happen when you're learning what therapies will be helpful and how well you can push them. If you're doing an intensive and you're just getting worse the whole time, I would argue the wrong things are being done. My goal with intensives is that individuals leave better, right? That we figured out what's going on, and that if we are fixing those areas in the brain, symptoms should be getting better and resolving more and more. Same thing with vestibular vision therapy. Do symptoms flare and do people feel symptomatic after a care here? For sure it happens, but I pride myself and our staff on being really good at knowing how much to push people and when to back off. So I'd say that doesn't happen a ton here. It happens, but I would say not nearly to the extent that it does elsewhere, because a lot of other places are just pushing. They kind of have the mentality of no pain, no gain. And when it comes to concussions, no pain, no gain is not the best thought process to have. The other question, I'm thinking in context of if someone comes from an intensive program, so best to have a companion along with them. Great question. So yes, that is always a great recommendation. And for my individuals who are local, early on in their care, depending on their symptoms and their severity, I always suggest a loved one is with them, because we don't know how they'll respond. Sometimes individuals can't drive afterwards. But once again, that's not every time. That is just, that shouldn't be happening every single time. So if that is happening, then that's a problem that I think needs to be addressed. So usually once we learn someone's fatigue point, then they may not need a companion with them. So you know how to juggle the balance of improvement versus crashing. Yes, that is pretty much the name of the game. And that is where I think chiropractic neurology, or one might call it functional neurology, really shines, is understanding fatigue points and how not to crash people. That's something that I try to instill in all my therapists, is that balance between improvement and crashing. And if we're doing our job, there should be more improvement and less crashing. I always tell patients, if they crash 1 or 2 times, that's okay. If they're crashing every time, then they can just slap me across the face, because that should not be happening every single time. If it is, we need to back off or figure out something. So that's a great way to put it. Any other questions before we sign off? If not, thank you again, everyone, so much for coming. Thank you for the great questions. I hope that was helpful. I hope that was informative. And I hope everyone has a great evening. And hopefully you'll join us for some of the future webinars. Thank you so much.